So I'd like to now introduce Dr. Carolina Reyes, Medical Director of Maternal and Fetal Medicine and Obstetrics and Gynecology at Virginia Hospital Center. Welcome, Dr. Reyes.
Thank you. And I want to thank you, Russ and Gynecology and Milt, really for bringing this together as early as a couple of years ago and making this a reality. And very much want to thank you for your passion, your determination, and your focus, because that's really what creates sustainable change. And so thank you for bringing that to this group. My talk is on addressing disparities in corticosteroid use. Let me see. I think, is this the green button I use?
The green button.
Okay, great. And this was a challenge. I mean, well, actually, let me just tell you what I'm going to talk about is, one, recognizing the disparities in preterm birth, identifying disparities in the use of antenatal corticosteroids, and then, as we were charged, to provide some recommendations in creating sustainable change. So I was going to say that, when Milt first asked me to come and to give this talk, I thought, there's not a lot of information on disparities in antenatal steroids, and I want to thank him really for inviting me to do this, because I think I've learned a lot about sort of these challenges in terms of, trying to address our issues and really bringing this to focus. Just overall, as we've talked about preterm birth, and I wanted to provide some of these slides to provide sort of some reality check in terms of what we're talking about. Clearly, preterm birth has been pretty stable, and we've only recently begun to make some changes in reducing preterm birth over the last 20 years. Clearly, there are disparities by region in preterm birth. Higher rates, certainly in the South and in Nevada. But when we talk about preterm birth, it isn't one sort of homogeneous population. I mean, clearly there are factors that are creating some of these disparities, not one by region, also by race, ethnicity, and we know these, that certainly a higher percent of live births in a black population, and more specifically, though, it doesn't tell us about the individual heterogeneous populations among the other categories, such as Hispanic, Asian, and the white category, because there are stories to be told in terms of a specific increase in rates among specific populations. In terms of the very preterm by race, clearly, as we know, a higher percent, 3.7% of live births in an African American population. What is more stunning is the toll that it takes, not just in costs to hospitals, but also the cost to lives. In looking at total and preterm related infant mortality in a black population, and that's the very first column, that 45% of infant mortality rate is due to preterm delivery. In a Puerto Rican population, 41%. And overall, it's 36%. In terms of live births by Hispanic origin, wanted to give you sort of, and I think we know most of this, but just wanted to remind us about a little bit more specifically some of the characteristics associated with preterm birth. And in terms of looking at vital statistics, this is sort of the forest for the trees. That clearly in a black population, higher rates of less than 1,500 grams, less than 2,500 grams. We know higher rates of preterm birth, generally to mothers who are less than 20 years of age, multiparous, and unmarried. If we look more specifically in the categories of Hispanic populations, we can see that in a Puerto Rican population, the rates are also significantly higher for less than 2,500 grams, preterm birth, young mothers, unmarried. Let's see, where do I point it here? Okay, great. And again, we've talked about the sentinel work that was done even before 1994 But it was in 1994 when the NIH Consensus Development Panel came out with the statement that corticosteroid use did indeed improve the lives of our preterm deliveries, and with a substantial decrease in morbidity and mortality. And it was one of the few, it's almost revolutionary. I mean, I don't think that there's many things that have occurred in these last 25 years that have truly changed the practice of obstetrical care. And this was one of them. Clearly not only had a high association with improving lives, saving costs together, which it doesn't always come together. And so there was really no question that everyone should be providing corticosteroids when indicated. In looking at some of the data regarding the use of corticosteroids, the published data, Meadow et al. Did a study with two different things. One, they looked at what was published in the literature from 1985 through 2000, and then asked practicing obstetricians, what is your current practice? And are your colleagues using this in about 2000? And basically, as we see, the percent of anticortical use in bold in the middle column here began to increase not in the 1985 to 1990, but certainly after the consensus statement. We see a rise, and I'm not sure if I have a laser here, but a rise in the middle column, 1994 to 1995, basically beginning to see an increase in the use of corticosteroid use, but still substantially low. And in 2001, still at near the 80 percentile. And over the last 14 years, we really haven't changed that. Thank you. We really haven't changed that percentile very much. What was interesting in the study that they did is they, in addition to publishing the review of the literature, then asked practicing physicians two questions. One was, what's the percentage of obstetricians that you think are using antenatal steroids in these different years? The second question was, is it in your personal practice to administer antenatal corticosteroids? And what was interesting, when they compared the literature, as I showed you in the prior slides, the percentile for what was documented in its use in the purple little histogram here, the purple column was clearly different than what the practicing physician was saying. Yes, my colleagues are practicing. So in 1985, the obstetricians were saying 31% were using steroids, when in fact in the literature it was documented at 8%. And overall, there was an overestimation of what their practicing obstetricians were doing, or what they thought their colleagues were doing. What was interesting was with the second question is, what is in your practice? It was interesting that in each of these columns, they rated themselves much higher than they rated their colleagues. That yes, maybe only 31%, but I was at 58%. And so, and I didn't add that column, but it was clearly much higher with every single year. So it was very interesting, the perception in terms of what we are doing as individuals compared to what we think our colleagues are doing compared to what's documented in the literature. And so clearly there was wide acceptance of the use of antenatal steroids for preterm birth, but obstetricians really recalled a much greater use of this than what was actually demonstrated. Another study by Dr. Goldenberg and his team, and this was a little bit more recent, mailed out a questionnaire to almost 2,000 ACOG members. The response rate was 59%, and it was on actually the evaluation of management of preterm birth, but very specific question on the use of corticosteroids. And what was reported by ACOG members was that 99.5% reported the use of antenatal corticosteroids in anticipation of a preterm birth. And again, our current rate is in the 80 percentile, but yet we are, in some respects, our perception is that it is being used widely. And interestingly, the earliest use was at 58%. I think now there's a growing trend to begin to use it at 23 weeks as opposed to 24 weeks. And the latest period, some were using as late as 33 weeks, but some at 34 weeks. So there was a little variation in terms of their earliest period and their latest period. And these were the following medical indications that they reported for their use. Interestingly, I saw in this article that 24% of practicing ACOG members did not have access to a NICU in their delivering facility. So when we look at the data that exists on corticosteroid use among births, there's a paucity of data, so you have to bear with me here. But the current database using the CDC vital statistics, and I have to thank Milt for helping me come up with some of this data here, is basically the data is a yes or no question, and it's using birth certificate data, asking the question, were corticosteroids used on the birth certificate? And so we see this is basically just percentage of live births, that in a white population, 18.9% had a use for corticosteroids. And so this tells us basically that all this tells us is that there's a differential in the percent of live births among these various populations. When we look through by race ethnicity, again, very similar findings, but in a Hispanic population overall, less number of live births that required or were documented that used corticosteroids. One of the things that the vital statistics do show, and this is the National Vital Statistics Report, is that on birth certificates, those live births that required corticosteroids tended to be a younger population, meaning under age 20 or older, and clearly 40 to 54-year-olds, higher rates of using corticosteroids. Now, there are very few studies that provide much more detail to the use of antenatal steroids among preterms. And I want to thank the CPQCC and Dr. Gould, who is here, who has been championing this for many years. And in the what CPQCC does is, as we may all know, collect data on more than 90% of NICU admissions in California. And they link their data to the California Vital Statistics. And of that, during this time period, between 2005 and 2007, there were 15,000 eligible neonates, and they found that 23% did not receive antenatal steroids. But more specifically, then provided some individual data on this linked data set. And one, again, that similar pattern, that maternal age, there was a higher rate of those that were less than age 20 in California that did not receive steroids, that were born between the indicated period. Interestingly, when the race ethnicity was broken down, there was a higher rate in the Hispanic population that did not receive steroids. And prenatal care had an association. In fact, no prenatal care, a higher risk of not receiving steroids. And then also where a child was born. So the regional higher level NICUs, higher rate of receiving steroids, and in a community or intermediate level hospital, less chance that they'd receive steroids. Also in terms of looking at payer mix, if they were self-pay or other, had a higher rate of not receiving steroids. But in the multivariate analysis, in terms of looking at many of those factors, the prominent risk factors that actually stood out were lack of prenatal care and the neonatal level of care. And so that may tell us a little bit about where patients deliver. So it wasn't necessarily about insurance or race ethnicity, but it really was about whether they had access to prenatal care and what region they lived in and where they delivered. These were the obstetrical conditions that were related to not receiving steroids. a vaginal birth, which may indicate they came in very short period and delivered, fetal distress, and gestational age. And interestingly, the later in gestation, closer to 34 weeks, the less chance that they'd receive steroids. And so to the point where neonates being delivered between 30 to 34 weeks of gestation, there was a six-fold increase in the adjusted odds at 34 weeks. In other words, a six-fold increase of not receiving steroids. So in the end, in the different studies very few studies that are available, there's really no treatment difference by race ethnicity that is documented. And when adjusted, may be related to socioeconomic factors, access to prenatal care, and maybe some physiological differences in preterm labor. There are a lot of limitations to this national data that we do have. And the birth certificate data is very valuable, but it doesn't allow for the assessment of appropriate use of steroids, as Dr. Kotelchuk was telling us. Doesn't provide accurate assessment of variation by geographic region, by race ethnicity, and it doesn't provide accurate information regarding the timing of delivery in reference to admission or diagnosis of preterm labor. So in conclusion, there's significant room for improvement in terms of antenatal steroid use. We have very limited information by specific factors. And yes, there are significant disparities in preterm birth. We know by race ethnicity, geographic region, maternal age, prenatal care access, but there are no significant disparities by race ethnicity in using, in the documented data that we have. I was surprised to see the disparity in our perception of whether we give corticosteroids and what we see as what we think our colleagues give, and then what's in the literature. And as we were charged, wanted to provide some recommendations. One, these are a little bit more general, but an investment certainly in research and improving our current obstetrical databases, an investment in effective quality improvement collaborative efforts, and in sustaining the improvement. We have some studies that have demonstrated some increase in improvement, but the challenge has always been to sustain that improvement. Certainly dissemination of information of quality programs and investment in galvanizing our advocacy efforts to address the gaps in care. So to that end, I'd like to introduce Dr. David Paul as our next speaker, who is going to give us his examples in Delaware on race and antenatal steroid use. He is from Christiana Care Health System as the interim chair in the Department of Pediatrics. So thank you.
Thank you, Carolina, and thank you, Milt and Russell, for organizing this conference. I think everybody in the room appreciates your efforts, and it's also great to be representing one of the small 5 states rather than the big 5 states, along with Rhode Island and 3 other states that I could guess it. So, I'm going to talk a little bit about our data from Delaware, but specifically from Christiana. But certainly there are many racial differences in perinatal outcomes that we all know about and were just mentioned. There are racial differences in premature birth, large racial disparities in infant mortality, and racial differences in maternal mortality as well. In addition, there are many differences of racial disparities within the healthcare delivery system. Disparities in cancer care, orthopedic care, emergency room care, and the literature is just replete with many examples of disparities in care. As one example, and let's bring it back to my home state of Delaware, I'd like to point out the racial differences once again, racial disparities in infant mortality. And we can see that in Delaware over this 5-year period, 2006 to 2010, Black non-Hispanic infant mortality was 14.1 per thousand live births. Our white non-Hispanic infant mortality was 5.4, and Hispanic infant mortality 7.4 per thousand live births. And that disparity ratio for African American to Caucasian is about 2.6, which is high and certainly the same as it is in the United States in general, about a 2.5 to 1 infant mortality rate. So let me share with you a study that we performed at Christiana on antenatal steroid, corticosteroid delivery, and racial differences. And to give you a little bit of background, Christiana Care is a regional level 3 neonatal intensive care unit in Delaware. The Delaware demographics include a population of 71% Caucasian, 22% African American, and we are right now at about 8% Hispanic in Delaware. And this study that I'm going to share with you, these data are a little bit old now. It was published in 2006, and the data go back to between 1993 and 2001. We looked at about 1,400, in this study, very low birth weight babies. So it's important to point out that these are babies just less than 1,500 grams, a little different population that we usually look at for delivery of steroids. Our population in our NICU, and it's also important to know that this is a NICU population, not necessarily babies who are stillborn or died in the delivery room. Our NICU population is 53% Caucasian and 39% African American and about 6% Hispanic. So note that the Delaware population in general is 22% African American. So not unexpected, we had a disproportionate representative of African American patients in our population. Now, I broke down the data here not by delivery of steroids, but by delivery of race, because I think it's illustrative to look at why the differences in what brings African American and Caucasian babies to our NICU. So again, in this population, there are no differences in race, in birth weight between Caucasian and African American babies, no difference in gestation. Maternal age was slightly higher in the Caucasian population, not surprisingly. Inborn proportion was equal in each group. And we were able to determine neighborhood income by zip code, and it was slightly higher in the Caucasian population. When we looked at our very low birth weight babies, again, the Caucasian group, the mothers were more likely to have a history of infertility. The African American mothers were more likely to have rupture of membranes. There was the African American population had a slightly higher rate of clinical chorioamnionitis, no difference in premature labor. The Caucasian population had a higher rate of multiple gestation, and preeclampsia was equal between the groups. Now, in this study, we looked at not only antenatal corticosteroid delivery, but cesarean delivery and tocolysis. You can see on the left-hand side is the unadjusted odds of receiving steroids, cesarean delivery, and tocolysis in Caucasian population compared to African American population. And I can say, just parenthetically, we did not look at the Hispanic population in the study because the numbers were just too small to do multivariable analysis. And we can see after controlling for the factors listed on the bottom here, Caucasian mothers had an increased odds of receiving steroids, an increased odds of receiving a cesarean delivery, and a slightly increased odds of receiving tocolytic medications compared to the African American populations in this study sample. So we concluded that in our population, and again, very low birth weight infants, Caucasian mothers were more likely to receive antenatal steroids, tocolytic medications, and cesarean deliveries compared to African American populations. And there's certainly some limitations to these data. Some of the data are older, dating back to 1993 in the NIH consensus conference, and that data emerged over time, as we just saw, that delivery improved over time. This was from a single center, limited to babies less than 1,500 grams, and we couldn't control for all factors, including insurance. But I would like to kind of bare my soul and show you our data from our institution and a subsequent study that we did that's not yet published, I should say. I worked on it with a fellow, but was reported at a national meeting. And in this study, we looked at antenatal steroids between 2006 and 2009. This was a later cohort in our single center. We did include 23 weeks gestation in this cohort because we had some data that, at the time, published from our center that there was some benefit to receiving steroids at 23 weeks, which I think is a whole other topic of discussion here. There were 1,700 patients, in this case mothers, between 23 and 34 weeks gestation, and we can see that only 61%, unfortunately, and I'm going to show you some data at the end that's a little rosier. Only 61% of the patients in this population receive steroids. Here we can see the differences are broken down by steroids given or steroids not given. And in this cohort, there was no differences in insurance, no differences in race, and no different in either service or private patients in the cohort that received steroids or the cohort that didn't receive steroids. So in this subsequent cohort, in our same institution, really couldn't find any differences based on race in the delivery of steroids at the same institution. There were some other interesting findings that I think I'll share. Here, in our multivariable analysis, these were the factors that were determined to be associated with not receiving any antenatal steroids. As we just saw, women who had a vaginal delivery compared to cesarean section had an increased odds of not receiving steroids. Now, back to the timing issue, those women who delivered within 12 hours of being admitted to the hospital. So this was time to door to time of delivery, and we picked 12 hours somewhat arbitrarily, but I think nobody would argue that that should be a sufficient time to give steroids. The odds ratio for not receiving steroids was 6.3, so again, emphasizing the timing issue here, that was the factor with the highest odds ratio. Those women who had induced labor, surprisingly, had an odds ratio of 2.4 for not receiving steroids. Now that's almost unexcusable, right, in this population. You're inducing labor, but certainly one of the other factors was a gestation greater than 32 weeks. It was just pointed out. So those women in the 32 to 34 week category had an increased odds of not receiving steroids. So are there disparities, racial disparities in the delivery of care? I would just say within our institution, in an older cohort, less than 1,500 gram babies, we seem to find it. In this later cohort, which is even a little bit old now, more expanded, we couldn't find any disparities at our single institution. But let me just speculate on some reasons why there may be disparities in care. Certainly there may be provider-level differences between groups. I think we've seen that with neonatal intensive care availability and the kind of services that different racial groups throughout our state receive. There may be certain insurance level differences within our state. And I'd like to postulate about physiologic level differences. Carolina postulated about physiologic differences in premature labor, but I'd also like to think about the baby, and I think there's a bias that, and there's known physiologic differences that African American babies do a little bit better, have less respiratory distress in the NICU. And there's disparities on race in that outcome and on gender, and I wonder if that in any way influences decision making. That obstetricians may think, boy, we know this baby's okay, black female, we don't have to worry about it quite as much. Just one speculation. And certainly we've talked about the recognition of premature labor. So just to end on a brighter note here, here's some data from our hospital, Christiana. These are babies less than 1,500 grams as benchmarked to the Vermont-Oxford network, which was mentioned. Now, we've only been a member of the Vermont-Oxford network since 2003. We can see the bottom line there as our Christiana Care data on delivering steroids that go back to 1993. You can see that after the consensus statement, there's been a slow, steady increase over time. For a lot of years, we were below the benchmark for the Vermont-Oxford network, and you can see since 2009, we had a slow, steady, but significant climb upwards, where we're now up about above 80% and but above the Vermont-Oxford network. So just a success at a single institution in increasing our delivery of steroids. And a lot of that came through just kind of throwing these data up there with the obstetricians and talking it through, and really a lot of embarrassment to say, look where we are compared to our benchmark here. That was very successful in improving our delivery. So thank you very much. Be happy to take questions along with Carolina.
Thank you very much. Thank you for your presentation, and also thank you for the review. One thing maybe I'd like you to comment a little bit about, which is, yes, we don't see the disparities in terms of antenatal steroids in particular. Seems there doesn't seem to be much bias when a woman arrives, regardless of race or ethnicity. But what you did show in the analysis is very much there are different problems in terms of access of perinatal care. So this is more of a question, but have folks come up with interventions around specifically saying, all right, we have a certain socioeconomic group, and we're going to jumpstart them through a perinatal care process, specifically with the idea of making sure that they get steroids on board, as opposed to granting them a full range of services that might be available under perinatal care. Certainly, as a goal, we would want everyone to receive those services, but have folks try to target and say, okay, we know we want to get steroids on board. Can we look at the socio-demographic group and try and get them through the system in a better way?
Well, thank you. I think this is the group to help maybe talk about some of those efforts. Certainly March of Dimes had their preterm birth toolkit that they distributed within hospital systems to help hospital systems in terms of addressing some of the workup for preterm birth. But in terms of, I think that this is where I don't have a lot of the answers in terms of the prenatal care initiatives on improving access to prenatal care, but clearly some very specific efforts, mainly through insuring patients and making sure that there was some level of insurance. And especially in California, I think we've seen that allowing for those that are undocumented to have access to care during pregnancy clearly increased the access to prenatal care in the very first trimester. I think it's up in the 90 percentile range as compared to other states. Medicaid rate eligibility, in terms of their eligibility for Medicare, I think it's at 300% of poverty level or below that they qualify for Medicaid, whereas in other states it's 150% or below. And again, that limits access to care, and I think by far that is probably the number one big elephant in the room, is that level of access to care. But it does speak volumes in terms of is that a marker for other factors, and certainly that we're not identifying that are associated with poverty and their risks for preterm birth. But in terms of your question, are there initiatives that have helped? I was involved in a Healthy Births initiative, a pretty large one in Los Angeles County that Dr. Liu, who's not here, was also very involved with. It was a $28 million Healthy Births initiative, specifically to help focus on improving birth outcomes. And we were targeting those that were at highest risk prior preterm delivery. And we were targeting the highest risk and trying to identify women, providing case management services for nursing services, not quite the old model because we didn't have the funding for that, but a level of case management or nursing service for a period of 2 years, not just through that pregnancy but beyond. And looking at the large effort, there's some slight changes in preterm birth, some slight changes in decrease in infant mortality for those specific regions, and these are certainly the most underserved areas in LA County. But it was a pretty massive effort that is actually still underway, and it included a quality care initiative with the community health centers, looking at how do we improve the level of care that's provided in that prenatal care effort. Pretty massive undertaking. I can't say we've demonstrated definitely population-based changes, but it did bring people together to talk about what are the best efforts, and the challenge is sustaining that effort, and I think that's where we are there. But I don't know if there are others that can comment on prenatal care initiatives to help address preterm birth.
Not comment on that, but I just had a question. I was curious about the 32-plus week group at your facility, Christiana. Were they majority ruptured membranes patients, or did you analyze that at all?
I don't know that. We can certainly go back and look at it. And I know there were differences at the time that we did the study on the recommendation for delivery. And I'm speaking as a neonatologist, so forgive me. But I know at the time there were differences in the recommendations for ruptured membranes in that population. So I'd have to go back and look at that. Frankly, I don't remember if we broke it out like that in that subpopulation.
And the other question I had was, do you primarily use one steroid regimen versus another?
We primarily use betamethasone at this time. Now, dating back to that, if you're looking at the 1993 data, over time we've used a lot of dexamethasone, but within the last certainly 4 to 5 years, we've transitioned to using almost extensively betamethasone.
Yeah, I was just wondering if the complete course would be more complicated because you have to give more doses of dexamethasone and there's more chance for not giving it.
Yeah, and certainly some of that data again would have gone back to the time where some dexamethasone was used, so that could be a complicating factor. Yeah.
Dudley from San Antonio again. I'm curious about, you found that induction, women who were being induced had lower rates of steroids. Is it because those were women that were infected or came in with chorioamnionitis, and so there's been a prevailing opinion, which I think is refuted by the data, that giving steroids in the context of infection is potentially dangerous? Do you think that might account for some of those changes?
Yeah, I think that's similar to the last question, and I think we'd have to dig deeper into the data to try and figure that out.
I suspect that's what's driving that more than anything else. I find it curious that they don't want to give steroids to women who are African American with female babies, because that was when I was training in residency based upon the collaborative project done in the States published in 1980. That was the group that actually benefited most from steroids, was 28 to 32 weeks African American women with female babies. And I trained in Iowa, so it meant we gave it like twice in 4 years. So I think it's curious that they say that that's a reason to not give it.
Well, just to clarify, that was David Paul, my personal speculation
I know,
on why they're...
I mean, it might be, but I just think it's a curious thought.
So when you start to think, why would there be differences in delivery of care, it's kind of hard to fathom. And I would certainly like to think that there's not overt racism where somebody would sit and say, I'm going to deliver care differently to one group compared to another. But I think there may be some subtle biases in our thinking, that's just one way that doctors think, and right or wrong. So.
But I don't know that this necessarily applies to this situation, but one of the concepts that I learned about a few years ago is the whole concept of intergenerational stress in the African American community on the basis of slavery from generations ago, that there are epigenetic changes that are then passed down through the generations that continue to affect the population today. That's what we're dealing with. I mean, some of it is socioeconomic, but still, if you correct for socioeconomic status, African American women are disproportionately affected. And it may be they're suffering the sins of all of our fathers. One concept, and I'm going to kind of switch gears here a little bit on how, because one of the things you talked about a lot are barriers to care. And the reason why I bring it up is because I've been involved in a whole other project. It has nothing to do with preterm birth, looking at patient navigation and prevention of cancer. This is something that comes, Milt brought out the cardiac emergency analogy, but cancer prevention is another, it's kind of analogous to preterm birth prevention a little bit. Patient navigators have been very effective in addressing barriers to care and systematic barriers for especially women of lower socioeconomic status. And I've been trying to wrap my mind around the model that we use for that into this, and I can't quite figure out how it would work. But I think an analogy here is like a perinatal care coordinator. And if you really have someone who is dedicated to addressing those kinds of barriers for women in the healthcare system, then that might be a way to address some of the systematic barriers that patients experience. I don't know, I'm just putting that out as an idea.
Calvin Hobel in Los Angeles had a West LA preterm birth project that demonstrated the comprehensive wraparound services for women that are at risk for preterm birth clearly decreased the recurrence of preterm birth in that population.
Yeah, I think that's a great idea, and certainly the value of that has to be shown. That's expensive, right? To hire a bunch of navigators, so I think it'd be important to look at the value. And just to comment on, from the last session, somebody mentioned, and I'm sorry I didn't catch the name, about, well, maybe this is a public health problem and not a hospital-based problem, but just to point out, as we move to a population-based risk model, this is a hospital problem. And so certainly providing care that may prevent costly NICU hospitalization and morbidity is going to be a hospital and system problem as well, along the same. So there may be tremendous value in patient navigation.
That was the goal of what we were doing. We had a grant from NCI to study the impact of navigation. That's what it was. I mean, I agree. It has to be studied to find out.
So, Scott Burns, Marshall Times. I know that the focus of this discussion is on racial and ethnic disparities, but we have Dr. Paul up here, who's a pediatrician. I'm a pediatrician. One of the questions that comes up in thinking out of the box, Milt, is what's the role of pediatricians or neonatologists versus the obstetricians or even nurses, nurse midwives, et cetera. So maybe you can just reflect a bit, and perhaps this is for later, on if we're going to do this sort of population-based or public health and or hospital initiative later on. I mean, how do we engage the pediatricians, the American Academy of Pediatrics, the perinatal section, and our OB colleagues to get something done here?
Well, certainly just at a system level, again, showing our data and benchmark, as I mentioned, benchmark to the Vermont-Oxford network, showing that to my obstetrical colleagues had a tremendous impact and was a tremendous way to move our system and improve care. We have, as many people in the room know, great statewide initiatives in Delaware to reduce infant mortality and premature birth, and I'm very active in that as a pediatrician. But I think as we also go back to the life course approach and think about that, certainly preventing illness in childhood, preventing obesity, preventing diabetes, breastfeeding are all premature birth prevention initiatives. And it should really start with children, right? If we can keep children from being obese and we can keep children healthy, then we can have them be healthy in their reproductive years. And but you're right. Pediatricians think of this as an obstetrical problem, not a pediatric problem, and we need to change that view as well in my mind. It's important.
Ron Wapner from Columbia. The Maternal Fetal Medicine Network over the past 5 years did a study that's called the APEX study, but it was looking at basically activities at 21 hospitals across the country, both university hospitals and also community hospitals. And as a follow-up to that, we sent questionnaires out to physicians asking them a number of questions, but directly related to steroids is, do you use steroids in your practice routinely? And 99.6% of the patients said absolutely. We also asked a series of questions about, do you think there's sufficient information? Is this a proven treatment, et cetera? And their answers to that were almost consistently yes. We then looked at the same patients that were delivered by the physicians, of which 99.6% said they used steroids. And the good news is that 93% of the babies delivered by that group had received, of appropriate patients, had received antenatal steroids. And our requirement to say that they received steroids is they could only be in labor and delivery 4 hours or less and deliver. If anybody that was there more than 4 hours and delivered, they would have been somebody that was not appropriately treated. So from that standpoint, the numbers continue to increase and improve. When we asked the barriers, it was interesting about why patients didn't get the steroids that they were supposed to get. There were two interesting things. Number one was fear of injections by patients. And number two was patients' lack of understanding of the benefits of the treatment. They just couldn't understand how giving them a shot would make some difference. But I think the bottom line point is that there really is continuing improvement with more and more patients. The only other issue that made a difference was and you were talking about OBs and pediatricians, and being an MFM specialist, I'm proud to say that one of the things that did make a difference was having an in-house maternal fetal medicine physician. That didn't mean they were there when the patient came in, but they set the culture and they came up with the protocols, and they basically mandated that at their particular hospital this was the standard treatment. So actually, I think it demonstrates that the numbers are continuing to improve, and that makes a really big difference.
Charlita Guillory, and I'm from Baylor College of Medicine and Texas Children's Hospital. There are just two comments that I want to make. The first is, I think you mentioned very easily and very clearly that African American babies, of course, have a higher infant mortality rate. And we talked about the very premature babies, which has this constant number of 3% overall in the 3.4% overall in the population, but it's 6-point-some% in African Americans, and it hasn't changed. So that's why I think the comments that were made earlier is so important. It appears that once the African American baby arrives in the neonatal unit, they benefit from best practices, and they benefit from getting the steroids. But my concern is what happens before they get there. In your study, did we look at, did they arrive late, and did they get 2 doses of steroids? Did they react the same to the steroids with their babies? Did they benefit from it? But more especially, I'm concerned about the access in terms of how they arrive. So I think as we look at the whole picture, we really do have to determine what happens before they arrive. Once they get, and if they get to the right hospital, might be okay. But do they go to other hospitals in terms of access to care? What about the providers there? So getting them to a tertiary level center care, as we're working in Texas right now, trying to determine where these babies are going, I think it's going to be very important as you look at the whole thing for African American babies. Thank you.
Thank you.
Yeah, thank you. I agree with those comments, certainly.
I wanted to just ask first, David, which sort of follows from the last comment, I think these are encouraging findings that once you reach a hospital, there's not a lot of racial differences in treatment. It would really be depressing if there was, or even by social class. I think these are good things. But did you in your study actually look, this is a question, at the number of by race who got a completed course or some measure like that? Because that's the issue that is sort of floating around. It's like, and I'm puzzled because I look at the few studies that are out there and I don't see a difference, and I think, well, I would have expected some, but no one ever did the next crosstab, and I wondered if you had and what you learned.
Well, in that first published study that I showed you in 2006, the answer is no, that those data, and I should have clarified that were just anti-steroids. And really that's the data we had. And that's, by the way, what the Vermont-Oxford network looks at as well. So that's something we should probably also advocate for within the VON, it was to look more carefully at that data. In the second group we did, and there were no differences on race based on receiving any steroids or number of doses of steroids as well.
Well, that's good, because because if we think that there's a difference in coming in, we should have seen, you would have expected to have seen a difference in completed course or not completed course. So, I mean, despite my arguing on one side, it's still, I'm encouraged by your finding. And then the other question I had, I guess it's more of a statement or a thought, which is, it sort of follows from the last speakers, that prematurity is such an important issue in the Black community in explaining disparities. So, the reason we had this session is because we want to make sure that this treatment opportunity, the secondary prevention, doesn't additionally burden a community by having access issues to receive. So I guess while I'm encouraged by, like our last speaker, that our numbers are going up, they are definitely going up in our bigger institutions, and we are clearly trying to get more people in to deliver their babies at level 3s. But as everybody says, there is still some gaps in who gets in and who doesn't get in. And I just wondered if you had any thoughts, Carolina or others, just sort of on the sort of interaction of sort of prematurity and access to treatment, and any random thoughts on it?
Random, I think it's our life, isn't it?
Yeah.
Other than to say as much effort as I think has been put into improving access to first prenatal care visit, right, in the first trimester, we thought that would be the answer, and it really hasn't changed our statistics very much, which I think is a little disappointing. And so I don't know what more to say other than to say I think that as we're talking about causes and risk factors, it really is looking at the larger picture, and I do really appreciate the life course sort of perspective, because as the patient walks into the door for that very first prenatal care visit, we already know those that are at significant risk, and it's already almost too late. So I think looking at it from that perspective, I think is incredibly valuable.
I think certainly go ahead, Dr. Young.
I just wanted to make a comment that a lot of this stuff, you have to be really careful with an average statistic, and it's wonderful that California and Delaware are doing well. But disparity could be, enormous in other parts of the country, so that although we can be somewhat encouraged, I think that the lesson to learn, even when we look at like 85% on average are getting it, there can be hospitals where the lack of getting it is just enormous. So I think although it's encouraging to show that we can close disparity in some locations, doesn't necessarily mean that there isn't huge disparities that still exist.
I think there's so many levels to look at this too. Certainly in Delaware, there's one large perinatal center that everybody has access to. So we're probably not a good model. So at that macro level, I think geographically everybody has access to. It's not access to the data, but if you start looking at a smaller level, neighborhood level, the types of providers that are there, the access, the transportation to that center that Dr. Kotelchuk mentioned, the messaging that goes out to the patients, the barriers to childcare, and all those small level factors that were mentioned in the first talk really need to be looked at to answer the question.
And I'm just going to interject here. One is I think Dr. Gould has some interesting data on antenatal steroid use per county. I don't know whether he's prepared to show that in California, but that I think has some bearing on this discussion. But let's take one more call and then one more question, and then we'll break for lunch.
It was just Eve Lackert's Gap Seattle. It's just a follow-up to some of the comments made about the approach to racism or racial disparities. And it's not, I think the term used was overt racism, or as soon as patients hit the door, we treat everybody equally. There are a lot of fields of medicine, I don't know about steroid use per se, many, many good studies that we don't have the same quality of care of patients by race. And what may happen in a Boston institute is very different than what you may see in Alabama, Texas, I don't know, other areas. So I do just want to caution us that there are subtle differences that we may not even be aware of, but that definitely occurs.
And I think that even just looking at the data on surveying physicians, practicing obstetricians, and asking them what do they do versus what they think their colleagues do versus what's documented in the literature consistently now, for the last 10 years, I think that you're right, that the perception is different than what is reality, and I think we have to keep that in mind.
Can I make one quick comment? Sorry, I know you said
Sure.
that. I was just going to say on that issue, the one thing we also have to keep in mind, though, is that the data, just because I think this will be a recurrent thing today, and I know we're going to talk about it later on our panel, is that what's in the literature, because birth certificate data isn't always accurate, we just have to think about what our definitions are and know that when physicians saying they're doing something 99% and birth certificates say they're doing it this, it's not just that the physicians are wrong. There's a lot of gray area there. So I think we also have to think about that as we keep our conversations going today.
So let's thank Dr. Reyes and Dr. Paul.